Thank you so much, everyone, for joining us today. My name is Amy Sam. I am the Health Education Project Specialist at the Maxwell and Eleanor Blum Patient Family Learning Center at Mass General Hospital. Before we get started, just wanted to go over a few items with you all. Please note that today's session is being recorded for educational purposes. If you're interested in viewing the recording, you may visit the Blum Center website at massgeneral.org/Blum-Center. Please note that everyone is in listen-only mode. Everyone has been muted so that we can hear our guest speaker today. If you have any questions for our guest speaker, you may use the chat feature, which is located at the bottom of your screen. We'll have time for them in the end. Only Blum Center staff and the guest speaker will see your questions. Please do not ask any personal medical. Please do not share any personal medical information or questions in the chat box. If you have a personal medical question, please ask your doctor. So next, I would like to introduce you all to Dr. Randy Miles. Dr. Miles is an assistant professor in the Department of Radiology at Mass General Hospital, where he serves as clinical service chief in the Division of Breast Imaging. His clinical research and public health efforts center around improving breast cancer outcomes through identifying barriers to breast cancer screening, creating patient-centered initiatives to improve access to breast imaging services, and examining how to improve delivery of high-quality, guideline-coordinated breast care for all patients. In recognition of Breast Cancer Awareness Month, he joins us today to give us a talk on breast cancer screening. So please join me in welcoming Dr. Miles.
Good morning. I'll be speaking on breast cancer screening, current guidelines, and controversies. Again, I am Randy Miles, Clinical Service Chief of the Division of Breast Imaging here at MGH. So here is an outline of what we will review today. I will give a general overview of screening mammography, review current screening guidelines. We will then talk about the limitations of mammography and how advanced imaging techniques may overcome these limitations. And lastly, I'll briefly wrap up how to have informed conversations with your physician about this topic. I would first like to thank the Blum Center for inviting me to present today, because lectures like these are so important for patients. Patients and families need evidence-based information to support informed conversations with their physicians. This quote sums it up perfectly. A curious patient is a healthy patient. Patients who seek out health information are able to advocate for their own health needs and are better equipped to collaborate with their physician to make health decisions that best suits their needs. I want this talk to be as widely applicable as possible for our patients today. So we'll start off with some basics and build from there as we discuss the topic of breast cancer screening. So first, some basic information about mammography. A mammogram is just a low-dose X-ray of the breast that allows a doctor to look for suspicious findings in the breast tissue. We perform this exam to detect breast cancer when it is small, before a lump can be felt, when it is easiest to treat. Mammograms come in two different flavors. First, we have a screening exam, which is what we will focus in on today. These are the exams that women without symptoms receive, so a radiologist like myself can evaluate to ensure that a cancer has not developed since the patient's last mammogram exam. Women will receive 2 standard views of each breast, which I'll show on the next slide. These are essentially only 2 results that can result from this exam. The first is everything looks great. There's no abnormalities. You can return to routine screening. The second result is that there isn't an indeterminate finding that needs further evaluation. If there is a finding that needs further evaluation, the next exam that would be performed would be called a diagnostic mammogram. For the diagnostic exam, a finding can be further evaluated with additional mammographic views and ultrasound. A definitive result can be reported with essentially one of 3 recommendations. First, the exam is normal. You can return to routine screening. Second, the finding is probably normal, resulting in some type of short-term follow-up. Lastly, the finding is suspicious, which may require tissue sampling or result in a biopsy. Not to confuse you, but there are other reasons that you may receive a diagnostic exam, including if there's an abnormal finding that is on another imaging modality, such as if it was seen on a chest CT, or if you have breast symptoms that your doctor wants further evaluation of. For example, if you have a breast lump, nipple discharge, or breast pain, you would come in and directly receive a diagnostic examination. So standard views that we obtain during a mammogram include CC and MLO views. The CC view, in which we compress the breast from the top and bottom, and the MLO view, which is an oblique side-to-side view, allow us to pinpoint the location of potential abnormalities in the breast if they are present. So here's an example of a mammogram or X-ray of the breast, as stated earlier. This is a CC view in which you compress the breast from the top to the bottom. Just give you a little bit of anatomy here, because I know some people are usually pretty interested in this. This is nipple here. We have skin here. This breast is pretty fatty. The way we can tell that is that it's pretty lucent. We don't see a lot of dense breast tissue, which has the appearance of being white on the mammogram. Some of these lines that you're seeing here are just normal vessels. Outside of just kind of normal structures within this mammogram, there is no abnormality. A radiologist like myself will interpret the images when you do receive your screening mammogram. If there is a suspicious finding, then the radiologist will be the one who performs the biopsy. I want to point out that the radiologist is a doctor who is able to answer questions about breast cancer screening and treatment if you have them. Take advantage of this resource if you have questions about society recommendations and or pros or cons of screening while receiving your exam. So here's some of the abnormal findings that we are looking for on your mammogram. These are all magnified, so we don't have the full mammographic view shown here. All these cases came back as cancer. So again, just to do a little bit of teaching, because I know a lot of times patients are interested. So again, like before, we see kind of that lucent or clear area within the breast. It's all normal fatty breast tissue. Here we see a dense mass here with, looks like there potentially is some spiculations, but a little bit obscured by some of the tissue. Here we just have some suspicious calcifications. We would call these pleomorphic, which means they're different size and shapes. These have the features of suspicious calcifications. And it looks like there's an underlying mass here as well with spiculated margins. Here we see architectural distortion, which means the tissue is just kind of pulling together. You have lines that are kind of pulling to a central point. Anytime we see that, we're just concerned that there may be an underlying mass that's causing that distortion of the tissue. So these are all findings that if we saw these on a screening mammogram, you would be called back or recalled for a diagnostic exam. So some findings are not as straightforward as those shown on the prior slide. And the finding is truly indeterminate when we bring the patient back for a diagnostic workup. So I know a lot of people want to know, what could it be if it's not cancer, if you do see something abnormal on that mammogram? Sometimes we see these areas that may appear mass-like, but what they end up being is just overlap of normal tissue. Other times, these masses actually do represent masses, but they're benign masses. So they may represent a cyst or a fibroadenoma that could be better appreciated when we characterize them on ultrasound. For calcifications, there are a variety of benign appearing calcifications that develop within the breast, including normal breakdown of fat, something we call fat necrosis, or there may be calcifications that layer within cysts. At the diagnostic examination, we will be able to further characterize the findings seen on your mammogram and determine whether or not you require a biopsy. So the report to your doctor will be largely standardized using the breast imaging reporting and data systems, otherwise called BI-RADS, which allows for consistent, accurate communication and follow-up. The report will be given with the final recommendation encoded as a BI-RADS 0 through 6. So this is not something you need to memorize, but I do want you to understand the concept. Every mammogram exam is coded with a BI-RADS score to direct the next step of care. So if you see your actual report on your MyChart or your patient gateway, there's a corresponding action that should be taken according to that BI-RADS category. So for example, if you have a BI-RADS 0 coded, it means that you need to return for additional breast imaging. If you have a BI-RADS 4 or a BI-RADS 5, tissue sampling or a biopsy would be recommended. You will receive a lay letter in the mail that's in plain terms that outlines the results of your examination, whether normal or abnormal, along with a statement on breast density, usually, and then the next steps of care. So this is something you definitely will receive. But if you are looking at that report, just realize that BI-RADS category, it does have a purpose, and there should be a recommendation that corresponds to that. So now that we have gone over that brief overview of mammography, how we go from a screening examination to a diagnostic examination, I think it's important that we really step back and understand, why do we screen? So many of you have seen this statistic: about 1 in 8 women in the US will develop breast cancer in their lifetime. In the US, that results in more than 270,000 women being diagnosed with breast cancer each year. Over that same period, more than 40,000 women will die from breast cancer. So the goal of screening, again, is to identify breast cancer while it is still treatable and curable. You can see that the difference in survival here based on stage of disease, comparing localized disease, which is early disease detected prior to spread outside of the breast, compared to distant disease after cells have spread to other parts of the body. The earlier we detect cancer through screening, the greater the opportunity to catch it at a point where it's localized, where the 5-year survival rate is 99%, versus catching it later, where it may have time to metastasize and to turn into distant disease, where the survival rate is a lot lower at 5 years of 28%. We can also see the importance of screening mammography in reducing breast cancer mortality on this graph. Since widespread use of screening mammography in the United States, starting in the early 1980s, age-adjusted breast cancer mortality in women has steadily decreased since this time. Also supporting this are 8 randomized controlled trials, which have been performed and published, and they have largely supported the benefits of breast cancer screening. These randomized controlled trials are our strongest evidence in research. Their study design involves randomly assigning participants into an experimental group versus a control group. These trials have essentially shown that screening mammography reduces breast cancer mortality by at least 20%. The first was initiated in 1963, the health insurance plan trial, which included over 62,000 women aged 40 to 64 years from the greater New York area, that showed a reduction of 22% among women invited to screen. If you look at the chart, you see that the outlier has been the Canadian National Breast Screening Trial. At 25 years of follow-up, breast cancer mortality was shown to be identical between the mammography screening and control arms. But this study has suffered from multiple flaws of the study design and suboptimal image quality compared to the other RCTs listed here. In terms of study design, the first round of screening had significantly more women with palpable and advanced breast cancer randomized to the screening arm, which should not have occurred due to this trial's intention to evaluate screening mammography. And as I've stated before, when we're screening, these are asymptomatic women who do not have symptoms, that are just being evaluated, their mammogram is just being evaluated to see if the cancer has developed in the interval. And then the most recent RCT in mammography was performed in 1982 in Sweden. And there, approximately 52,000 women aged 39 to 59 years were randomized. And after 14 years of follow-up, there was a 23% mortality reduction. So while there may be differences in specific recommendations among societies, there is one thing that is not controversial. And that is that there is consensus among national health organizations that mammographic screening in average risk women is overall beneficial in reducing breast cancer mortality. And that's been supported by the trials that I mentioned that I covered on the prior slide. Key differences, however, do exist, when we discuss recommended age to initiate screening and then the frequency of a routine screening. So under the organization there, it's almost like an alphabet soup in terms of the different organizations that have recommendations for breast cancer screening. Here are some differences between these major societies in terms of recommendations. I've highlighted 3 major societies here, including the ACR, the American College of Radiology, which in conjunction with the Society of Breast Imaging has specific recommendations, have recommendations in conjunction. The American Cancer Society, and then the United States Preventive Services Task Force. And these are societies and recommendations that doctors most commonly use when they're making their screening recommendations. If you were to ask a radiologist, in general, you would likely receive the ACR recommendation from the first row here that recommends starting annual screening at age 40. This was widely used by everyone until the USPSTF updated their recommendations in 2009 to recommend screening starting at age 50. If you ask your internal medicine doctor or oncology doctor, many times the second row is often the recommendation reflecting the American Cancer Society recommendation of starting at age 45, and then transitioning from annual screening to biennial screening at age 54. And then lastly, if you likely ask your family medicine doctor or other primary care providers, the third column may be the recommendation that you're provided that starting at age 50 with biennial screening is the recommendation. So first, I think it's just important to understand that there are differences in the different guidelines, but they're pretty much based off those 2 factors: age starting, and then how often we're screening. So differences in screening recommendations, in these kind of 3 different categories are largely based off balancing the benefits and harms of screening. The primary benefit of screening, as we have discussed, particularly starting at age 40 years of age for average risk women, is that it represents the greatest reduction in breast cancer specific mortality. Also, earlier detection results in decreased treatment-related morbidity, because smaller cancers that have not spread can be treated with less invasive therapy. So for example, if you do have a small tumor that's localized to a specific quadrant of the breast, that tumor likely can be removed with a procedure known as a lumpectomy or breast conserving therapy versus having to have a mastectomy or the entire breast removed. Also, if there's no spread to the lymph nodes, then a sentinel node biopsy can be performed versus a axillary dissection, which is associated with lymphedema and other morbidity. So it's important to recognize all 3 guidelines that I've highlighted. Like I said before, recognize that annual mammography should remain an option. And specifically it should remain an option for women starting at age 40 based off their preferences. Annual screening starting at age 40 saves the most lives, and that's supported by this study here. Annual screening mammography of women ages 40 to 84 prevents more deaths from breast cancer than biennial screening of women 50 to 74 years old. As you can see, we have a mortality reduction of 39.6% in the former group versus 23.2% in the group that starts at age 50 with biannual screening. So here are the harms associated with screening. And like I said, when we look at these guidelines that recommend less frequent screening or delayed screening, the big goal is to reduce these harms. So let's review each of these. So while women younger than age 50 years are more likely to develop more aggressive disease, there is a lower incidence of breast cancer within this group. As a result, we do see a higher number of false positive examinations within this group. And a false positive exam is a test result that suggests the presence of a disease when the disease is not present. So I'll give you an example. If a woman comes in, we read her mammogram as her screening mammogram that there is a finding that's indeterminate that requires her coming back for a diagnostic examination. And potentially she could potentially have a biopsy based off that diagnostic examination. If the end result is that she did not have cancer at the result of that biopsy, then that screening examination, as well as the diagnostic examination, is considered a false positive examination, because we had determined that there potentially could be disease, but in the end, there was no cancer diagnosed. So on average, an individual woman aged 40 to 49 who undergoes annual screening mammography will experience one false positive mammogram every 10 years. Biannual screening, screening every 2 years, reduces false positive mammograms by 1/3 compared with annual screening. So to sum this up, starting later, delaying the screening age, and less frequent screening leads to less false positive exams, and less false positive exams is a good thing. So why do we care about false positive examinations? False positive examinations may impact mental health. Compared to US women of the same age who do not receive a false positive exam, women who experience these exams are more likely to experience short-term psychological distress, including anxiety about breast cancer and worry over perceived risk of future breast cancer. These effects, however, do appear to be time limited and do not impact a woman's future intention to screen. In fact, studies have shown that up to 98% of adults in the United States surveyed who said that they were recalled following a false positive examination were actually satisfied that they had the additional imaging. Another impact of these false positive examinations are the economic impact at both the individual and population level. Subsequent examinations following a false positive screening exam, such as the diagnostic examination and the potential biopsy, have their findings that suggest that the amount of money ranges from $134.80 for follow-up imaging to over $1,000 for more invasive testing based off these false positive exams. In a 2015 study examining US healthcare expenditure data of more than 700,000 women, an 11% annual false positive rate among screened women aged 40 to 49 years was estimated to cost an additional $2.8 billion annually. At the individual level, I want to point out that the ACA requires screening exams be covered without a copay. This is not the case for diagnostic examinations. Those examinations when a woman is called back from screening. So an excessive number of false positive screening exams can cause financial burden for multiple patients who may have to pay out of pocket for these exams. And again, these are patients who, like I said, we find out eventually do not end up having cancer. So radiation risk, it is an X-ray of the breast. There is a small dose of radiation. I will say that modern machines have really minimized this harm, in which we use a very low dose of radiation for high quality images. Radiation dose for a mammogram is equal to the exposure from 7 weeks of natural surroundings. So just kind of being outside in your normal day-to-day activities. So obviously, if you decrease the number of screening exams by delaying the screening age or increasing the interval between exams, you can decrease the amount of radiation that a woman is exposed to. The 2016 US PSTF recommendation, however, stated that radiation-induced breast cancer, so we're concerned that the actual radiation that you're receiving from frequent mammograms resulting in a radiation-induced breast cancer or death is thought to be very low. At most, 2 to 11 deaths due to radiation-induced cancer may occur per 100,000 women. So that equals out to a 0.002% to 0.011% of women screened, which is infinitely lower than the actual risk of dying from an advanced cancer if it is not caught. And then lastly, I just want to discuss this topic of overdiagnosis, which is often cited as a harm. It refers to screen-detected breast cancer that would not have progressed to clinical presentation during an individual's lifetime. Estimates of overdiagnosis range from 0% to 50%. And the reason that percentage is so large is because it requires significant assumptions that may overestimate the results. This is due to the fact that we have no way of evaluating currently which breast cancers will progress into clinically significant disease. The USPSTF acknowledges that methods for estimating overdiagnosis at a population level are not well established. Because we cannot make this determination, let's say a woman does develop a, we'll kind of just using the premise of overdiagnosis. Let's say a woman does develop a clinically insignificant cancer based off this premise in her 40s. She would still have that cancer identified in her 50s if she delayed screening. And based off that, that tumor would likely still be treated. So in essence, we are, in using this as kind of a reason for harm, we are increasing the chance that we are delaying the diagnosis of a clinically significant cancer rather than preventing treatment of a clinically insignificant breast cancer by delaying screening based off the fact that we can determine, based off imaging, whether or not this cancer is likely to progress or to stay indolent. And so until we can prospectively determine clinically significant versus insignificant, if that is a true thing, breast cancer with a degree of certainty, it's very challenging to have a productive conversation based off just the overdiagnosis topic. So, reasons for talks like this, and the reason that many of the guidelines I think have done a great job of saying like there needs to be discussion about screening. Just because women really do need the tools to have informed conversations about the benefits and harms of breast cancer screening. We'll comment on a little bit more on the harms and in terms of balancing out the benefits and harms. I think it's important to note that both false positives and overdiagnosis are risk of all screening tests. It's not just unique to breast imaging, so just starting there. I think it's also important to understand that this balance can be adjusted based off the facility women receive their screening. There's large variability in interpretive performance by radiologists who interpret mammograms. Studies have shown that recall rates, which is radiologists seeing a mammogram and potentially seeing an abnormal finding and having the woman come back for additional images for her diagnostic exam, that they vary widely and can range from like 3% to up to 30%. And a lot of that recall rate has to do with radiologist expertise and experience. So as you can imagine, if there's a radiologist with less expertise who's recalling 30% of patients back, issues such as false positive exams become a big issue. It becomes a great issue that can be associated with a great degree of increased psychological distress and economic harms for that patient population. But if a patient goes to a facility with breast imaging specialists where they're only calling back 5% with high accuracy, as you would see at a place like, as you see it here at MGH, these issues become much more of a moot point. Lastly, as we improve our techniques and utilize new technology, there's just going to be further reduction of the radiation dose associated with mammograms. And it's already something that's very, very, very low, but that's something that will continue to decrease over time. So there are supplemental tools that can also help to balance some of the benefits and harms of mammography screening. And those tools are 3D tomosynthesis that's being performed widespread in the US currently, screening ultrasound, contrast enhanced mammography, and MR imaging. While mammography, it is the only imaging modality proven to reduce breast cancer specific mortality, it does remain an imperfect test. Interpretive performance characteristics of mammography are reduced in subgroups of women who are at increased breast cancer risk, which can lead to false negative examinations and delayed breast cancer diagnosis. I think the group that many people hear a lot about are women with dense breast tissue. These women do have a increased breast cancer risk, about 1.2 to 2.1 fold higher than women without dense breast tissue. Because they do have that dense breast tissue, often, or it can happen that a cancer can be obscured by that dense breast tissue, which may delay a diagnosis. So the use of these advanced techniques purport improved cancer detection over just using the 2D image alone. And as I've said before, the appropriate use of these tools for screening can really help to maximize the overall benefit to harm ratio that we've discussed before. So we'll kind of go through these individually. So the digital breast tomosynthesis or 3D imaging is a relatively recent advancement in which tomosynthesis images are constructed from a series of low dose images. It is performed at most centers now during the screening phase and has led to improved screening interpretation when combined with 2D digital mammography imaging versus the use of 2D digital mammography imaging alone. And there's accumulating evidence that shows recall rates and cancer detection rates are improved with the use of DBT. I think I'll get questions about, what imaging study should I have for my screening? And the one thing that, I think is universal that I would recommend, no matter, what the density of your breast tissue is, that you're going to a center that offers 3D imaging or digital breast tomosynthesis, just because it provides that it provides additional information that can help the radiologist find a cancer that may be overlapping dense tissue. And it may also help to prevent you from being brought back or recalled for your diagnostic examination because looking at those individual slices, we're really able to evaluate the breast and to see if that finding may just represent a summation of just normal tissue that's overlapping on itself. And this is a study by Miller that showed that the addition of 3D tomosynthesis imaging led to a 29% increase in cancer detection and a 15% decrease in false positive rates. So these are both these are positive findings, and there have been subsequent studies that have shown similar results. So if you're interested, this is what the tomosynthesis images look like, and I'll kind of point out here. So this is the 2D image here on the left. On the right, these 4 images here, these are all tomosynthesis images. They're slices throughout the breast. These slices limit the effect of overlapping tissue, and they allow us to potentially see if there's a mass that's underlying, that's within that dense tissue. You can see here that there is a mass that's here that's kind of within this yellow square. But if you were to look at the 2D image, it really is kind of hiding within this dense tissue. Like we had seen on that previous mammogram, this is the fat within the breast, kind of this more lucent gray area. All of this white area here, this is all normal tissue. So as you can imagine, if the cancers on the mammogram are also white, if you have a lot of this overlying dense tissue, could obscure the mass. So here you can see, not seen very well in the 2D, but as we start going through those slices of the breast, this is more clearly seen here and really limits that masking effect. So screening breast ultrasound, this is another tool that has shown some additional benefit in women, particularly who have dense breast tissue, because it does really help to reduce that masking effect of the dense tissue on cancers that could be in the underlying region. So compared with screening mammography alone, screening ultrasound in combination with mammography can increase cancer detection and has been shown to detect 2 to 4 additional cancers per 1,000 examinations in women receiving screening breast ultrasound. So increased false positive examinations. Increased false positive examination rates associated with this use are not insignificant. However, we do see findings that end up not being cancer on screening ultrasound, they may that may require further intervention or imaging. Other limitations of screening ultrasound include that it's largely a time-consuming, operator-dependent examination requiring technical expertise, which may limit utilization. So typically you would need someone who's gone through additional training, such as like a sonographer, who would come in and scan the patient, or a board certified physician to come in and to take the finding for what they're seeing on the mammogram and to look in the setting of diagnostic, that would be the case. But in the setting of a screening breast ultrasound, you would need a sonographer or a board certified physician to come in and screen the quadrants of the breast and to look in that subareolar region. So newer technology, including automated whole breast units, have actually been shown to yield similar result as handheld ultrasound, which I think most of the patients here have probably been more exposed to the handheld ultrasound. So this may help to improve utilization because with these whole breast, automated whole breast units, you actually don't need technical expertise in terms of being able to scan real time. You just need the training to apply the unit. And from there, the machine will do the whole breast ultrasound, which alleviates the need of a sonographer or a board certified physician to perform the exam. So here's an example. Again, we have a 2D mammogram, and then here we have an ultrasound image. You can see, so this is a mass that is seen within the breast tissue. Just to give you a little anatomy, here, this is skin. This is fatty breast tissue, more of this white area here. This is dense breast tissue here. So you can kind of see the differentiation between the fat and the dense breast tissue here. As you're following this here, you can see that this mass is completely within the dense breast tissue. And then on the mammogram corresponding to the same breast, again, you see the dense breast tissue here, and that mass is located within this dense breast tissue. So you can see it can be a little bit challenging to identify this mass in that 2D imaging, but as soon as you put that ultrasound probe on the patient in that area, you can see that this mass is a lot easier to see, and it really removes that barrier of having dense breast tissue mask, these masses. So that's a big benefit of using breast ultrasound in women with dense breast tissue. So contrast enhanced mammography is becoming more and more popular, but is not widely used yet. Just by providing the contrast and imaging, we're able to identify properties of the tumor, including angiogenesis, that is induced by breast tumors, their ability to kind of recruit and create these leaky blood vessels. So these tumors, they uptake the contrast, and there's washout based off this, based off the features of these blood vessels being very weak and leaky. So these properties allow us to identify cancer among a background of normal breast tissue. The exam involves a double exposure using both low and high energy X-rays, resulting in areas of enhancement with the background parenchyma subtracted from the image. And there's more and more evidence there has been over the years that has accumulated that demonstrates improved lesion detection compared with 2D digital mammography alone. So again, we just have some images of just to show you an example. So again, in the center here, we just have the 2D image. Again, we're seeing that same feature of a dense breast. Again, skin, thin line here, we have nipple here. The loosened or gray area here, this is all fat surrounding the dense breast tissue, which is more white or dense here in the center. And when we perform these contrast enhanced mammogram images, we'll give the contrast and then we're able to subtract out the background tissue. So you can see that the dense tissue is not as big of a hurdle. You don't necessarily have to look through this to try to identify an abnormality. So that's subtracted out. And then we're left with this mass here that's demonstrated the ability to uptake contrast. So you can see it stands out in relation to the rest of the tissue. This would be very challenging to see if you were just giving this image. And this could be one of those cases where there's a cancer that's present, but not able to be identified on the 2D image because of this dense tissue. And I will comment that, there's been numerous meta-analyses on CEM where, these meta-analyses, they take the results from multiple studies has demonstrated that CEM has very high sensitivity, in the 90, above 90%. But it does have some limited specificity, meaning that there may be other findings in the breast that enhance that are not cancer. So I think as we're kind of using this technology, it's important for radiologists to be very comfortable and have a lot of experience, interpreting these examinations so you can limit those false positive examinations because of the effects that we've discussed earlier. So lastly, we'll discuss breast MRI. Compared to digital mammography alone, breast MRI screening has been shown to increase the diagnostic yield of small node negative tumors. It is the most sensitive supplemental screening technique with an additional cancer detection rate of 15.5 per 1,000 women screened. The American Cancer Society actually recommends annual breast MRI screening in women with a lifetime risk of greater than 20%. But there have been many studies, and the field is really looking at expanded use of this technology, especially as we look at abbreviated protocols and techniques in women who may be at intermediate risk or women with dense breast tissue, where a mammographic interpretation may be limited. And again, similar imaging findings. We have a woman with dense breast tissue here, and just like I haven't mentioned it before, but just kind of as we're kind of deciding between whether a woman is dense or not, really looking at the fibroglandular tissue here, and if there's a greater than a 50% of this fibroglandular tissue of this white area compared to the fat, which is clear or lucent on the mammogram, then that woman is considered dense. But as I've said it before, if there is a tumor there, it can be masked. This is the same exact breast. This is a MIP, something we call like a MIP image for the MR. You can clearly see within this MR image, this mass that's here that stands out clear as day that we can identify here. And unfortunately, when you look at the mammogram, there's really no way to see that this finding as clearly. Potentially, it could be better characterized with 3D imaging, but I think it's easy to say that this image here makes it a lot easier to identify this tumor compared just to the 2D imaging alone. And I'll just make a last comment just about just kind of using these supplemental tools. These should be used in addition to mammography. Mammography is our best tool in terms of identifying breast cancers. And I think these advanced tools here we can use to supplement and really help to bolster up mammography where there are limitations, such as when you are dealing with a woman who has dense breast tissue. These tools can really be utilized to help support breast cancer detection in those women, but these should be used kind of as a supplement, not as a replacement. So preparing to talk to your doctor, I think it's important to talk about some of these issues. I think it's very clear that the benefit of breast cancer screening is that, especially with mammography, especially when we're looking at that 40 to 49 year age range, is that it optimizes or increases our ability to find breast cancer early. Especially in that age group where breast cancers are more likely to be more aggressive. But I think it's important to be able to talk to your doctor and come in and have an informed conversation. I think the first thing to realize is that you do have options. All three guidelines recognize that annual mammography should remain an option for each woman starting at age 40. Based on the discussions with your physician. So this is something you should definitely feel empowered if you're, under the age of 40, or even if you're, within that age range, if your doctor's made a recommendation that you start at age 50, to say, can we step back? Can we talk a little bit about this so you can have your, just so you can be fully informed and fully understand what the basis of that recommendation is. I think it's important to understand your comfort level with waiting to screen, and understanding which scenario you're more comfortable. Some women are going to say, I'm uncomfortable waiting to age 50 because I know that if I do develop a breast cancer in that time frame, it's more likely to be aggressive. So I want to be super, not to use the same term, but super aggressive in terms of, screening and understanding if something has developed, because I want to make sure I catch it early. Someone else may have a different mindset where they say, I know that breast cancer doesn't, even though the overall trend is that we are diagnosing more breast cancer, but someone may have the mindset to say, like, I know there's a lower incidence, or that breast cancer occurs less frequent in younger women. And I'm okay with waiting to age 50 because I know that that incident is lower. I mean, these are all things that you really want to bring out and have that informed discussion with your doctor. And there are multiple doctors that you can have this discussion with. Like I said, you can have it with your primary care doctor. You can have it with your OB-GYN. If you do have access to a radiologist or breast imager, you really can talk to, different physicians and really come up to what is the best solution for you. The other thing that to realize is just kind of understand your risk factors. I think when you do come and talk to your doctor, you really want to understand, are you at increased risk for breast cancer? Because that is something that really does change. It changes the game. I think this talk is really focused in on average women who are at average risk. And we have talked a little bit about women with dense breast tissue or a slightly increased risk, but women who have, strong family history, who have certain genetic syndromes or mutations. Those are things that if your doctor hasn't discussed with you about, or if there's something that you know about that you haven't talked to your doctor about, you really need to make sure that that is provided, because there are recommendations. There are different recommendations for women who are at a higher risk for developing breast cancer. And also, if you were in your 20s or whatever else, you may have had a biopsy, like understanding that those biopsy results are important. And if you've either moved to a different city or moved to a different facility, ensuring that you have all the information so you and your doctor can have an informed conversation. But I do want to say on the topic, the fact about having family history, in particular, I think a lot of times that there's a lot of onus that's put on the fact of whether someone has family history. It's important to realize that the majority of women diagnosed with breast cancer, specifically those between 40 and 49, actually don't have a strong family history. So it's something to consider, but you want to make that as part of your decision, but not the only part of your decision. Really think about your comfort level, other risk factors. And then lastly, as we've talked about before, you also want to think about the benefits, which is what we all know, that you can find these cancers early if you're having more frequent screening, but also to think about the harms, and to understand what those harms are, and to understand how that would affect your day-to-day life, in terms of the screening more frequently. So I think these are things that you want to bring up and have thought out before you talk to your doctor, that can really help you find the best solution that suits your needs. So I think in conclusion, I think the big thing for me is that I want everyone to know that there is consensus that overall routine mammography screening is beneficial in reducing breast cancer specific mortality for average risk women. And I really want patients that come from this talk to understand that annual mammography should remain an option, and it is an option for every woman starting at age 40. Each guideline says talk to your physician, and then I really want you to think about those things that impact you and what's best for you, because this definitely should be a discussion that is a collaborative effort between a woman and her decision to screen and that physician, and definitely that the information to make an informed decision should be provided. And I think it's important to understand that, appropriate use of advanced imaging techniques can help support increase the benefit to harm ratio of routine mammography screening. So don't be afraid to ask your doctor about these extra tools. Ask them about, the screening ultrasound, ask them about the tomosynthesis. If you're at a screening facility, ask them, will I receive the 3D tomosynthesis images today? Just so that you're aware of the type of exams that you're receiving, because you want to, make sure that if you are receiving annual screening, you want to make sure you're receiving high quality screening, and you want to make sure that you can optimize the ability for that radiologist who interprets your examination, that they can accurately detect a cancer if it's there, but also improve their ability to not call you back if a cancer, if there is a finding that's not cancer, that may be a little bit indeterminate on your mammogram. And then in terms of future direction, this is the last slide. I think technology, there's going to be so many advances that are coming down the pipeline. There's so many exciting things in breast imaging that are on the cusp. I think one of those things that has been talked about a lot is artificial intelligence. I think it's really going to help us to identify those women who are, really it's going to help us to more accurately identify those women who are truly at increased risk of developing breast cancer. And I think that once we have these tools, more advanced technology, we really can get away from some of the one size fits all and better educate women based off the data, what may be best for them in terms of, their preferences, in terms of, screening at at the specific age, whether starting at 40, or, the intervals in which we screen. And then, risk-based screening, if we do have these more accurate tools, can also be used by healthcare providers to help inform women what's best for them. I think these are kind of like future direction. I think until we get to that point, it's really important just to evaluate the factors that I had discussed on a couple slides ago about, what your comfort level is, what the benefit to harm ratio is, and then kind of moving from there. But it is definitely exciting. We have some tools to detect breast cancer, early, and to, treat women, especially when we can catch these tumors when they are small and localized to the breast. But definitely it's something that, requires discussion in terms of what is the best strategy for each individual person. So I'll end there and I'll see if you have any questions. If you do have questions that arise later, you can definitely feel free to email me. I also do post a lot just on breast cancer topics based off evidence-based medicine, based off what's been published in the literature on my Twitter account. So if you're interested in seeing that, you can definitely follow me on Twitter at rmilesmd. And I'll stop there. Thank you for your time.
Thank you so much, Dr. Miles, for an informative presentation. We are now towards the end of the session. If you have any questions for Dr. Miles, feel free to enter them in the chat. So Dr. Miles, I do see that we have a few that came in.
Sure.
What do you think would be the downside of biannual rather than annual mammography in women beginning at age 40?
Yeah, so it kind of goes back to the delay in diagnosis. So, if we're screening every year, it just increases the chances that we are going to detect that breast cancer earlier. If we extend that time period out 2 years, if a cancer develops, in 6 months after that, that last mammogram that was negative, then we're not going to get a chance to see that cancer for another 1.5 years if you're doing the biannual screening versus 6 months if you were to come back after a year. So the biggest risk is just kind of like that delayed diagnosis if that breast cancer doesn't become symptomatic in the interval. And also with these, it also increases your risk of, having interval cancers, which are cancers that arise in the kind of in the middle of screening examinations. So if you have like a negative screening or normal screening examination, and let's say before your next screening examination, you have a symptom that brings you back in early, and a cancer is identified, that's called a interval cancer. Those cancers have a kind of a worse prognosis than those detected at screening. So by shortening that interval in which we screen, we're able to detect cancers earlier, and potentially when they are smaller and potentially more easier to treat.
So to flip it around, are there any studies that have looked into the usefulness of less frequent screening? For instance, 1 every 2 years for someone who is between the ages of 40 and 50?
Yeah, so I mean, there's so many studies that are comparing. There are a lot of studies that have looked at this. I think the for the and there's one that I mentioned earlier that was by Miller that compared based off the guidelines. So I think with the studies, they've pretty much been based off the actual guidelines that I discussed previous. I guess if you want to look at one of the pros of kind of the biennial screening, it does provide us a little bit, it does help in terms of decreasing the number of false positive examinations, like I stated earlier, just because we kind of have a longer time period to compare the mammograms. So if there's something that's kind of over 2 years, has just kind of slightly looks different, that's still within normal limits, you're more likely to be able to interpret that within reason, versus if it's kind of been 1 year, where you may be more apt to call that patient back. But based off the guidelines in terms of annual, starting at age 40, biannual starting at age 50, there's definitely increase. There's an increased mortality reduction, which is a good thing, on the screening more frequently at age 40.
Thank you. Is there an age that is considered too young for screening?
For screening, usually the cutoff age is 30, in which for a mammogram, and that's determined. That's just based off just kind of that women that are younger have very dense breast tissue, and there are some challenges with kind of the breast density when you are just using the mammography. And women that are screened in their 30s, those are women that are denoted to they're high risk for breast cancer. So those are women that either have like a BRCA mutation, who have a very strong family history. They usually denoted to have a lifetime risk greater than 20%. So these are the women that when they come see their doctor, usually like this at an age, they'll know this pretty quickly just because of that strong family history. But these are things that the doctor would recognize pretty quickly, and can actually do run a risk calculator. There are multiple risk calculators that can be used to determine lifetime risk. So they would be able to identify you as high risk if you're greater than 20%, and that would qualify you to start screening earlier. But for average risk women, the earliest that I would recommend would be to start at age 40.
Thank you. Are mammograms done in mammogram vans as reliable as those done in an on-site healthcare setting?
Yes, I'll say it's different depending on the facility, but they definitely are that we have to meet certain requirements based off the government. There's the MQSA criteria. So those mammograms are or should be as high of quality as one that you would receive at a facility.
Thank you. After a finding that requires further examination, how is a decision made on the type of testing, biopsy versus other imaging?
Oh, that's a great question. It varies because it just depends on what the finding is. Like for the screening examination, no matter where you go, you're going to get those two views of the breast, the CC and the MLO view. But once you come back, there's a few things that we look at. So if there's calcifications, we'll usually magnify them. So there's something called magnification views, just so we can fully characterize the morphology of those calcifications. If there's a mass or if there's something that we call like an asymmetry, we'll usually compress out the breast tissue because we want to make sure that it is a true finding and not just overlapping dense tissue. If there's any question that this is not overlapping tissue, then typically not. If there's calcifications, we typically would not perform an ultrasound. But if there's a mass, something that we call like an asymmetry, which is just kind of like a patch of kind of dense tissue, or that distortion that I described, those are patients that typically would go to ultrasound, and we would evaluate further with that. The way that we determine whether or not something needs to be biopsied depends on just the morphology, and that's something that's based off evidence of what cancers look like on a mammogram. So there are certain findings, like I showed you before, that you look at and you say, this is likely going to come back as cancer. It has all the features of what a cancer would look like on a mammogram. There are other findings where you're not as sure, but it meets a certain threshold where you would say, this needs to be biopsy because we need to understand what this represents. So it just depends on the morphologic features. And I think it's important to realize as you're if you do have a biopsy recommendation, is to realize that, actually most biopsy results don't come back as cancer. A lot of times they do fit in that category of, there's something in the breast that's developed since the last mammogram that is indeterminate. We don't know what this represents, but we need to know what it represents because it could represent cancer. So, when you do go in for the biopsy, just have that in the back of your mind that, that very well could come back as something that's not cancer, but it's something that should be biopsied. Because if it is cancer, we want to make sure that we can catch it early, so that if it does need to be treated, we can treat it soon, and we can increase the chance of survival.
Thank you so much. So it looks like we're just about that time. Before we end today's session, Dr. Miles, do you have any final thoughts you'd like to share with the audience?
Just like to say, I think, make sure that your radiologist is there, when you're going into the breast imaging suite, especially when you're there for diagnostic examinations. Definitely ask questions. I know for me, just like I was kind of pointing out different aspects of the breast on the ultrasound, I do that for my patients. I really like to explain. I think as a physician, it's our duty to make sure that our patients understand what's going on, why we're making our recommendations. So you definitely should be empowered to ask questions. And you guys are doing all the right things by being curious and attending talks like this, so that you can, do it, so that you can work in conjunction with your physician to better serve your health needs. So thanks again.
Thank you so much, Dr. Miles, for a wonderful presentation. Thank you so much, everyone, for joining us today. Hopefully you found today's presentation helpful. As mentioned earlier on, if you'd like to view the recording of today's session, you may visit the Blum Center website at massgeneral.org/Blum-Center. Thank you so much, everyone. Have a lovely rest of the day.
Thank you.